Now, if you're going, I want to shift gears and I want to talk about the last few slides. I want to talk about how do I build a sepsis program? How do I really, what are the things I need to consider to have a highly effective and efficient sepsis program? And I always say the first step is ED involvement. You have to have the ED. And the reason I think is shown on this slide. And so these are five studies all around the world looking at over 9.6 million patients. Of the 9.6 million patients, the 7.1% was sepsis positive. Very consistent with the very first slide we showed of about a 6%, 4 to 8% sepsis rate, 7% sepsis positive. And then the far two right columns is POA and non-POA. POA stands for sepsis was present on admission. Non-POA means sepsis was not present on admission. What you see here is 88% of patients with sepsis. Now, these are the sepsis patients. 88% of patients with sepsis present with sepsis on admission. And depending on, I've seen hospitals, the range is anywhere from 80 to 90% of the patients who have sepsis will come in through the ED with sepsis, through your emergency department with sepsis. So it's present on admission. So excluding the emergency department from your sepsis program, you're going to miss 88% of your sepsis patients. You have to have ED involvement. Now let's talk about the non-POA for a minute, non-present on infection. Why would it be non-present on infection? There are two reasons for that. Number one is you missed it. Someone missed it. When the patient presented to the ED, they had sepsis and it was a misdiagnosis. The number two reason is they get admitted to the hospital for some other cause, and then they develop sepsis as a late complication. So that's the 12% non-present on admission. Is there a difference in outcome between present on admission and non-present on admission sepsis patients? And the answer is there's a dramatic difference in the outcome of these patients. If you look at the bottom table, these are sepsis non-POA and POA patients. Hospital length of stay, if it's present on admission, is about 8 days. It's about 18 days if it's not present on admission, if you missed it or if it was a late complication. ICU length of stay doubles, goes from 5 days to 10 days. Duration on mechanical ventilation, 1.5-fold greater, from 6.6 days to 10 days on mechanical ventilation. Mortality more than doubles, goes from 11% to 25%, 26% in non-present on admission sepsis cases. And the cost per case more than doubles, goes from $18,000 a case to $51,000 a case. So there is a huge clinical and financial impact and outcome metrics of present on admission versus non-present on admission. So A, you don't want to miss them, and B, you do not want it developing as a late complication. Now, let's talk about having a program and how do I really build a program, and does it matter? And these slides, there's 4 different things here that I'll talk about. The top left, the green table, was a study that looked at basically 50,000 patients. And it broke the patients to hospitals between better nursing resourced hospitals and worser resource nursing level of nursing care that we have at these different hospitals. And there was a statistically significant difference in every parameter that between better nursing staffed hospitals and lower nursing staffed hospitals in terms of 30-day mortality of sepsis, 30-day readmission of sepsis, ICU admissions of sepsis, length of stay, ICU length of stay, the cost of therapy, and the cost of nursing care was actually lower in the better staffed hospitals than the lower staffed hospitals. The bottom left table looks at a program of complying with the CMS SEP 1 measures pre and post a sepsis program. And basically, compliance with the CMS guidelines improved, mortality improved. If you look on the top right, this was a study that was published in 2015, and they looked at 45 different sepsis programs. And they said, what are the key factors of a sepsis program that will make it effective? And they basically looked at, and this was back when they were doing a 6-hour and 24-hour bundle, but they said you can improve sepsis outcomes if you just do education alone. If you take education alone, you'll improve outcomes. If you change process alone without education, just do the process piece, you can improve outcomes. So if you just do education with no process change, you can improve outcomes, bundle compliance and mortality. If you do process change, you can improve bundle compliance and mortality. But if you do both, that's where you get the biggest bang for your buck. And in the bottom table, what you see is a study that looked at the financial impact of sepsis cases pre and post protocol, doing a sepsis program. And on the far right, what you see is the length of stay dropped and the cost per patient cost. You save about $6,000 per case of sepsis program. So, what are the things you need to consider? How do I build a sepsis program? And part of the things that I'm going to talk about is, if I already have a sepsis program, how do I make it better? First thing is screening. The mantra should be every patient should get screened every day, every shift. The most important thing I can tell you here is that sepsis screening does not diagnose sepsis. If you screen for sepsis and the patient is positive for your screening, that is not a diagnosis of sepsis. That only screens that the patient needs to be assessed for the presence of sepsis. And that's important. Lactate levels are part of the bundle elements. I think they really don't play a role in defining sepsis, but they do play a role in assessing on sequential lactate levels will help assess how effective your therapy is. You should start seeing these lactate levels go down. If they don't go down, then your therapy is being less effective than if they do go down. But there's two ways you can screen sepsis patients. You can do a manual screening. It's the advantage is you've got standardized data collection. However, it is extremely labor intensive. It is very difficult to do, and it's especially difficult to do every shift, every patient, every day. Now what has popped up on the scene are a lot of automated sepsis screening tools. How to label a patient as having sepsis is really meeting the sepsis definition. Which definition do you want to use? The sepsis 3 definition, I think using 2 out of 4 SIRS to say the potential of infection is wrong. I think the question is, can only a SOFA score be used to label a patient with sepsis? No, only a SOFA score cannot be used. The definition of sepsis is you have to have a presumed or documented infection. You have to have a suspicion of infection with potential evidence of that. And you have to have evidence of organ dysfunction due to the infection. And that's how you document it. So the digital screening tools, let me go back to the digital screening tools. These are automated systems that can screen patients automatically. There's no manual effort involved with that. The problem with that is there's still a high false positive rate. And just because you have a screening tool doesn't mean you're going to improve your clinical outcomes. On the right here, it says, which screening tool do I use? Various results based on the tools you use. And these are all the considerations you need to have when you build a sepsis program. And for the sake of our time here, I'm going to stop and not go through all of these.